Dr. Prerna AHUJA, please come on the dais.
Good afternoon, everybody. My topic is ocular presentations in leukemia, and I'll be talking about a case series of around 6 cases. So the first case is of a patient of ALL, and it was a T-cell ALL patient presented with a severe headache, ptosis, with having bilateral third and sixth cranial nerve palsy, loss of vision, PL- vision, and pupil was fixed 6 mm non-reactive, and the fundus picture looked like a bilateral CRAO picture. On clinical diagnosis, it was said that there's a CNS infiltration of acute leukemia, and the patient was started on a protocol which basically consisted of prednisolone, methotrexate, vincristine. And after 2 weeks of follow-up, the visual acuity was seen to improve, and at 21 days, it was seen to further improve, and the pupils also became reactive. And fundus, the hemorrhages were seen to reduce. And correlationally, you can see the platelet count is status quo. It's almost 1,000 change. This is the fundus photo. The fundus photo shows multiple hemorrhages that are seen in the pre-retinal hemorrhages. Superficial hemorrhages are also seen, and hemorrhages there at the macula as well. The white infiltrate can also be seen surrounded by the hemorrhage. Coming to the next case, it's a patient who has ALL. Both eyes diminution of vision was seen, and pupil were briskly reactive to light. On fundus examination, beautiful pictures of bilaterally presenting vitreous subhyaloid hemorrhage and superficial hemorrhages, pre-retinal hemorrhages could be seen. Macula was also involved in the right eye, in the left eye. Macula in the right eye also had a subhyaloid hemorrhage. Patient was started on IV antibiotics as the patient is presented with fever as well, and also packed RBCs were given, platelet transfusion was given, and patient was started on vincristine, methotrexate, and hydrocortisone, and the vision resolved to both eyes being 6/9. Case number 3, this patient presented with no complaints, no visual complaints, and on fundus examination, superficial hemorrhages could be seen in the superior and inferior temporal arcade, and whitish leukemic infiltrate type picture could be seen in the right eye. The next case, patient was a Philadelphia plus ALL chromosome on maintenance treatment and had multiple fever spikes. Patient also had features of ASOM, and on both eyes, vision was 6/6. However, the patient fundus was vitritis was present, and picture of retinal necrosis was present with hemorrhages along the inferior temporal arcade. Impression was made of having CMV retinitis and acute retinal necrosis with leukemic retinopathy. Unfortunately, the picture is not available for that. The next case, the last 4 fundus photos, as you can see, patient again had no symptoms. Only one rot spot could be seen in the superior temporal arcade, and one just above the macula in the left eye. Case number 6, what is of relevance is both eyes superficial hemorrhages, pre-retinal hemorrhages were present, and vision was dropped. Here also macula could be seen involved, and whitish spot could be seen, which is an indicative of direct infiltration. Coming to the discussion part, it is imperative that leukemic patients have to be worked up for ocular treatment because 90% patients present with will have ocular involvement. However, only 50% will have symptoms. Now, acutely, they can present with anemia, hemorrhage, or infection, and chronically, they can have indolent features, vague symptoms. Most commonly, acute will present to you, and myeloid will have more common. Adults are more common, and in late stages, you will see fundus or ocular in manifestations. Direct manifestations, we can see infiltrates. Possible leukemic infiltration with white-centered retinal hemorrhages could be seen. Hematological complications starting from subconjunctival hemorrhage going up to the last layer of retina hemorrhages can be seen. Opportunistic infections with CMV, herpes, mumps, uveitis, toxo can be seen. And secondary to treatment, that is vincristine and methotrexate, toxicity due to the treatment could also be seen. Now, direct manifestations can be whitish, grayish nodules, which could be small in size, and if the disease is fulminant, it could increase in size. Choroidal involvement, which is if the When there is serous retinal detachment, upon resolution, the detached retina, at the site of detached retina, there can be clumping of RP, so very classic leopard spot fundus can be seen. Subretinal infiltrates can also be seen, and vitreous opacity such as masquerade syndrome, which could present like panuveitis, can also be seen. What is of interest is if the patient has a vitreous infiltration, it is likely that the patient will have a CNS involvement and a positive CSF tap, especially in the blast phase. Now, anemia will have, as I have already spoken about, anemia, thrombocytopenia, and hyperviscosity are the hematological complications, and the patient can have neurological complications of papilledema and veno-occlusive disease, as we saw in the first patient as well. If your patient presents to you with macular hemorrhage and intracranial hemorrhage, we have to closely monitor, and patient has to be started on platelet transfusion. Coming to the treatment part, systemically, the patient has to be started on chemotherapy. Intrathecal chemotherapy can be indicated if CNS infiltration is seen. Cranial irradiation may be required. Ocular radiation, however, we have to keep in mind it can cause posterior subcapsular cataract. Blood transfusion, especially if the hemoglobin is low, and leukapheresis if the platelet count is very high. If the hemorrhages are not resolving, especially at the macular region, pars plana vitrectomy can also be seen. If serous RD is there, then also pars plana vitrectomy may be indicated. Thank you.
Thank you, Dr. Prerna. And all the patients which you have presented were already diagnosed.
Yes, so they were
With
all
all.
diagnosed cases. They were reference cases, basically, from the
So
onco
this
center.
is in the tertiary case setup. You recommend that all cases of
Yes, sir.
leukemia, the eye examination should be done.
Yes, sir, because 90% and 50% won't complain of anything. Like in my case also, at least 50% of the patients didn't have any complaints.
So
Visual complaints will only come in the later stage.
Yeah, so the take-home message is
All leukemia patients, ocular manifestations may or may not be present, but we have to do an ocular examination, including a fundus examination.
Thank you.